Dear colleagues and friends, I'm Laura Mertens. I'm an associate editor of the EAU UROONCO educational platform. And it's a great pleasure for me to introduce to you Associate Professor Twan van der Heijden. Welcome.
Thank you, Laura.
Yesterday we witnessed a very interesting session about TURBT and MRI within the diagnostic pathway of bladder cancer. And you explained why TURBT still is a crucial procedure. Could you please summarize your key arguments for this to the audience?
Yes, I can. Yesterday we discussed that the TURBT is a procedure from 1910, so that's fairly a long period ago. But this procedure is still being done. It's essential for histological diagnosis. It's essential to determine the presence of histological subtypes and the presence of carcinoma in situ, but also to assess tumor heterogeneity and prostatic urethra involvement, and also lymphovascular invasion, because that's something you can see on a TURBT specimen.
Yeah. And what's the value of performing a TURBT before neoadjuvant therapy?
Yeah, that's a good point. There's several reasons why to perform a TURBT. The first one is neoadjuvant chemotherapy, and the second one, to my opinion, is trimodal therapy. So the combination of radical TURBT and chemoradiation afterwards. And when you focus on the neoadjuvant chemotherapy, it's very important to look for subtypes. So normal urothelial carcinoma, so pure urothelial carcinoma is normally treated with neoadjuvant chemotherapy. But squamous cell or adenocarcinoma micropapillary normally is treated with an immediate radical cystectomy. So and then you leave the neoadjuvant chemotherapy behind.
So you can actually use it to guide treatment decisions.
Actually, exactly.
And another interesting development, of course, is the increased use of trimodal therapy. What do you know about the role or the importance of TURBT before trimodal therapy?
Yeah, good point. In trimodal therapy, you see that patients that have a visible complete TURBT do better. So they have a higher complete response rate compared to patients without that visible TURBT. And it's about 79 versus 57% complete response rate. So there's a significant difference between patients treated radically with TURBT.
But do you really think that's because of the complete TURBT?
That's a good point, because patients with a gross tumor most probably can't be treated with radical TURBT because the tumor is too big, and patients with a smaller tumor more likely undergo a radical TURBT. So there is a selection bias in that data.
So I think we can conclude that TURBT still is needed, but are there also any disadvantages of the procedure?
Yes, what we talked about yesterday, not everything is black and white. That's the same for TURBT. It has a lot of advantages, also some disadvantages. It gives a significant delay in treatment. It's possible that it might induce, I'm very careful in saying that, but it might induce the circulating tumor cells. And it might have some staging errors. That's what we see in bigger studies where patients with T1G3 undergo a radical cystectomy immediate, because 35% of those patients are understaged, actually.
So how would you propose to overcome these disadvantages?
Yeah, we can overcome these advantages by not performing a TURBT anymore.
Yeah, but we had to do it.
Do we? There are some studies that apply MRI, and instead of performing a TURBT to stage patients, you can perform an MRI and take, for example, a single biopsy to prove that it's urothelial carcinoma.
So is that what you're investigating in your blood paradigm trial?
Yeah, that's what we do exactly in the blood paradigm trial. The blood paradigm trial follows the bladder path trial. That is a British study. Randomized between an MRI and the TURBT for staging purposes. And what you see is that in patients with a muscle-invasive bladder cancer, when they were diagnosed with MRI, the time to definite treatment decreased by 45 days. The blood paradigm trial is more focusing on progression-free survival. So will the progression-free survival be better if we treat patients or diagnose patients with an MRI instead of performing a TURBT? And we have some secondary endpoints, and that is cost effectiveness, because an MRI is cheaper than a TURBT. We have a quality of life analysis, and also look at the time to definite treatment. But this is a study that's running in the Netherlands, and we started recruiting 1 year ago, and probably or hopefully we have the results in 2028, and we can say if we might skip the TURBT and go for an MRI and a single biopsy.
But until then, we keep performing proper TURBTs.
Until then, I think it's mandatory to perform a TURBT to stage patients with bladder cancer.
Thank you very much.
Thank you.